Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's Editorial Board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, welcome to the latest videocast in the Medicine Journal series. I'm Albert Ferro. I'm the chairman of the Editorial Board. And I'm delighted to be joined today by Professor Suveer Singh, who is a board member on medicine and in charge of the forthcoming issues. There are 3 issues coming up, the October, November and December issues of 2023, which are all devoted to respiratory medicine. So welcome to you, Suveer.
Thank you, Albert. It's a pleasure to be here and really enjoyable to be involved in medicine and obviously the respiratory chapters over the last 12 years now.
Gosh, long time. Do you just want to briefly say a bit about yourself, who you are and where you work and so on?
Yes, thank you. So I'm a consultant in respiratory and intensive care medicine and a professor practice in that at Imperial College London. I work at the Royal Brompton Hospital and Chelsea and Westminster hospitals. And I'm quite involved in beyond the clinical aspects of care, I'm quite involved in education and research, right through from undergraduate level through to postgraduate, and of course MRC P and postgraduate exit exams, both in respiratory medicine and intensive care medicine. So this for me is a real pleasure because it spans effectively what I do in all 3 spheres of clinical, education, and research.
Great, thank you very much. So maybe we'll start off with something from the October issue, which you actually have written yourself. Actually, it's the article on respiratory symptoms and signs. You also mentioned the MRCP UK exam, and obviously part of that is devoted to clinical skills, which includes, respiratory examination and so on. And I just wanted to get your views on whether you think the history and examination still play an important part in respiratory medicine, given that all of our patients, when they come through the front door, they'll all get a chest X-ray. They'll, at the drop of a hat, they can have a CT of their chest or even an MRI. What place is there still in those basic clinical skills?
Yeah, and it's such an important question. And obviously with the advent of generative AI, one might think that the days of standard clinical assessment are diminishing. I would argue against that, really for a few reasons. One is that we still need to understand the basis, the characteristics of symptoms and signs, the severity and the trajectory, to be able to get a better pre-test probability, if you like, of honing down on what we think the differential diagnosis is going to be. And of course, then we should use our investigations, which may well be at the front door. I think it continues to be important. If you go back to Lanac in 1816 and his invention of the stethoscope, and before and after him, that's continued to be important. And perhaps importantly, I think it can be an important rule-out test. So the sensitivity of auscultation, for instance, for picking up a diagnosis may be low to intermediate. But actually, if you get a normal examination that's done properly, you can rule out a number of tests. So I think assimilating that clinical examination together with a really detailed history will really help you interpret what the investigations really mean. And in the end, we all aspire to being good diagnosticians, such that we can be good, such that we can manage our patients well.
Okay, yeah, that seems very, very comprehensive. Thank you. Let's go to another article in the series, which was by Duncan Geddes. It's centered around the history of respiratory medicine. And that's quite a fascinating article as well, isn't it? And I wondered if you might sort of just pick out a few highlights there. And I think we were talking before about pharmacological versus technological advances. So maybe you could just sort of tell us a little bit around that.
Yes, no, absolutely. Thank you. And Professor Geddes, Duncan Geddes, is one of my heroes, like many people's heroes, a former president of the British Thoracic Society and at the Brompton Hospital for decades. And he was a careful thinker. And this idea of the pharmaceutical versus the technological, clearly, there have been enormous advances in every field of respiratory medicine in terms of pharmaceuticals. But in terms of, if you like, bang for buck, one could argue that the technology has actually been more effective in a shorter space of time. Examples of that? Well, if we look at non-invasive ventilation, whether that be CPAP, continuous positive airway pressure for sleep apnea, developed in the 1980s by Colin Sullivan in Australia, that has had a dramatic impact on what is an emerging and, if you like, underdiagnosed condition, not least in a world which is getting bigger and heavier. But the other really important bit of that is non-invasive ventilation for instance, COPD, which has become the gold standard. And we now talk of door to mask time, rather like in acute myocardial infarction, there used to be door to needle time. So those things have made an important and an enormous impact and continue to do so. It's a reference back to the origins of modern intensive care medicine in the polio epidemic of Copenhagen in 1952, where positive pressure ventilation actually started to save the lives of those people, those children, particularly who were not thriving on negative pressure ventilation. So that and the development of now newer technologies, bronchoscopic lung volume reduction, for instance, the use of valves in selected patients with emphysema, the use of cryotherapies to try and reduce the impact of hypersecretion in the airways. All of these things you can see are starting to emerge. Where they'll find their place, the new technologies, remains to be seen. But we know that non-invasive ventilation is here to stay and has an enormous impact on survival.
It's all fascinating stuff. I would definitely recommend our viewers go to that article, actually. So thank you for giving us that overview. Let's turn to another topic, which is obviously very important, very common, asthma. And this is a disease area where I think treatments have evolved dramatically over time. So I wondered if you might sort of give us a little bit of an overview of how the treatment of asthma has changed in recent years.
Yes. No, thank you. And it has changed enormously, and it continues to do so as a result of the, again, technology, biotechnology in particular, the use of monoclonal antibodies and the identification of particular endotypes, if you like. So we're moving away somewhat from the simple clinical terms of allergic and non-allergic asthma to different immunoendotypes. The Th1 and the Th2 types of asthma, which within that, again, you can then consider the eosinophilic asthmas and the non-eosinophilic asthmas, and you can even just by these first few sentences understand that it's becoming more complex, and as a result of that, we're able to select patients and therefore select treatments that will be more precise for that particular type of asthma. And examples of that are the IL-5 inhibitors, the IgE and anti-eosinophilic inhibitors, so omalizumab and benralizumab. But more recently, the development of tezepelumab, which has been shown to improve outcomes in terms of exacerbations and intervals between exacerbations in those patients, not just with eosinophilic asthma, but with non-eosinophilic asthma. So for the first time in a long time, we're starting to have treatments that are available, if you like, for those more difficult to control asthma patients. But I would like to just take it back, and this is where reading the articles, I think, will also remind us importantly that doing the basics right is so crucial. And asthma still kills up to 15,000 or so people a year in the UK. And understanding it and having understanding who the risk patients are, ensuring that monitoring and having written asthma management plans in place is still the bedrock of controlling asthma. And there's a term, total control, which broadly means complete control of symptoms for several weeks. And that's the aspiration, but it's still a long way away from that. And so I think we need to, and the articles will certainly talk about that, together with newer therapies, as mentioned. So bronchial thermoplasty, which is, if you like, zapping the airways and taking away one or two layers, which are associated with the smooth muscle contractility. Where its place sits, again, remains to be seen. But these are the kind of new developments on the back of reminders of the control of asthma and just good planning. That hopefully readers will be able to remind themselves of.
Yeah, no, sure. I mean, I'm very conscious of this being an asthmatic myself. I think the basics are very much the same, but the options for those who have more severe disease have certainly changed in the way that you describe. I guess the other thing that's very close to home for me is air pollution, because I live in the middle of London, and we've recently had the ULEZ controversy and focus on how important air pollution is in pathology in general. My particular specialty is hypertension. Cardiovascular disease, and there's increasing focus on how air pollution might be involved in cardiovascular disease. But in the context of respiratory disease, of course, it seems something that's been around for a long time. But it's obviously becoming increasingly focused upon. Can you maybe just give us a bit of an overview, a few thoughts on the role of air pollution in lung disease?
Yes, thank you, Albert. It is very important. Obviously, the lungs are the only organ that are directly exposed to the environment, and so it's natural to consider it. And the amount of work globally that has now gone into understanding the associations is increasing, and these are addressed in one of the chapters, and it links also to occupational lung diseases, which is an excellent chapter within respiratory medicine. I think there is an emerging understanding now that patients who have unexpectedly low lung function, for instance, and one can't find an obvious explanation for it through usual means, that going back to childhood and understanding what exposures there may have been, is starting to find certain associations that will say, yes, it was probably related to exposures, environmental exposures, and that could have contributed to this. And of course, the importance of that is that it may well portend shorter longevity over time. And that's why people are doing better and better epidemiological studies, not just cross-sectional but observational, and I think there's an emergence and an understanding now that the PM10s and the PM5s and the PM2.5s, i.e. the particulate matter that at size that influences lung diseases are very important, and as you alluded to, low emission zones are being driven by the science, actually, and the science is respiratory medicine, both pediatric and adult. And so I would urge readers to actually just look at that, because it is important beyond simply knowing that it is a risk factor. There's now evidence that suggests that you can quantify the risk and you can actually understand what the implications of that might be, at least on a population level.
Yeah, thank you. And just sticking with airways disease, so we've talked also about asthma, but COPD, of course, is the other major one that everyone knows about, and still very important cause of morbidity and mortality. I just wanted your thoughts about where COPD is going. Is it still increasing? Is it decreasing? I'm very conscious that smoking has been going down, quite significantly, at least in the UK, largely replaced by vaping, including in young people, but also in ex-smokers. So I wonder, given that, do you think that COPD is still, or is it going to continue to be an important cause of disease?
I suppose one can separate, shall we say, UK and Western countries where smoking restrictions and indeed bans are in place, from countries and regions where that is not the case. So the burden of COPD, one would hope, will diminish in those countries with smoking bans in place, because it remains the single important risk factor. Just as an aside, E-Valley, which is e-cigarette and vaping associated acute lung injury, is an entity that we now understand increasingly, and so we mustn't lose focus on that important small, albeit small, risk. But in terms of COPD, there is, as we are all aware of, an increasing complexity of the type of inhaled medications that are available, but now an understanding that in a lot of people, when you're going through the stages of COPD, you can halt it by stopping smoking at any one stage. The GOLD, that is the global obstructive lung disease stages, from 1 to 4. From 0 to 4, but also that the use of combinations of long-acting beta agonists plus long-acting muscarinic agonists, plus in certain patients the inhaled corticosteroids, can control disease. There are also mucolytics that are important in certain groups of patients, and then there are the proteinase inhibitors. So pharmacologically, there's a whole sort of gambit of different options. But then on top of that, as we mentioned earlier on, non-invasive ventilation for certain patients, and then in a certain group of patients with emphysema, the use of bronchoscopic lung volume reduction surgery if surgical volume reduction surgery isn't appropriate or too risky. And then, of course, in patients with mucus production and COPD, then these emerging technologies to try and reduce hypersecretion with anticholinergic agents and anticholinergic therapies that mechanical therapies that may find their place in a specific group of patients. So there's a lot of developments in pharmacology and also in technology. It still goes back to smoking cessation, and if we think globally, there's huge emerging middle classes in Southeast Asia and China, where bans are not in place. And so the global burden of COPD, if you look at WHO predictions, becoming the third biggest killer in the world within a decade. I think there's still a lot to understand about it. And therefore, again, I would urge readers to look at those chapters, if nothing else, to remind themselves of where we are with the algorithms.
Thank you. And you've talked about the pharmacological, you've talked about the technical interventions that are very effective. And what about pulmonary rehab?
Yes.
Does that still have a role?
Yeah, absolutely. And it's evidence-based. If you look at all the international guidelines, that has an enormous impact on that. And that's at least part of the reason why the GOLD criteria, the severity criteria, don't just look at lung function, they look at performance status as well. And we know that pulmonary rehabilitation can improve and sustain performance status of patients, which ultimately is what is important to them. Clearly reducing symptom burden, but then part of that symptom is the exercise capacity and their performance. And that's where pulmonary rehabilitation is a gold standard.
Okay, thank you. It's obviously very difficult in a short interview to cover everything that's in our three issues there. We'll maybe touch on a couple more. One which I think is probably worth mentioning is interstitial lung disease, because again, that's an area where major changes in management have happened in recent years. And perhaps I can ask you about that.
Yes, and it's a fascinating area, one of my interests, and just the idea that decades ago, something that used to be called cryptogenic fibrosing alveolitis, CFA, has now become, the diagnostics have become more refined, the categorization into the fibrosing lung diseases, some of which, the classical idiopathic pulmonary fibrosis, still portends a very bad prognosis, five-year survival of 50% or less. But then importantly, being able to separate those idiopathic cases that are going to progress from the ones where there are likely to be stability that can happen if you exclude or remove the drivers to it. And then importantly, the emergence of, again, pharmaceutical agents in the form of antifibrotic therapies that now have demonstrated evidence-based reduction in the decline of lung function in not just idiopathic pulmonary fibrosis, but in other fibrosing lung diseases. And therefore that opportunity to patients who are diagnosed with it to at least get some chance of slowing down the deterioration is there. And there are new molecules that are being identified all the time, TGF-beta and others, that will come up with new targets and new drugs in the next decade. That undoubtedly will have an important impact on slowing down the progress in certain patients of this terrible disease. But I'll take it back to the importance, and this is relevant to the chapters, of understanding the categorization of the different types of fibrosing lung diseases. What's interesting is that sometimes in medical school these days, there's still the concept of lung fibrosis, but it's a blanket term that covers those diseases that are interstitial lung diseases that are reversible. From the granulomatous diseases to the immune modulated diseases like lymphocytic interstitial pneumonitis, through to the fibrosing lung diseases, through to the honeycomb lung, which is a final common pathway of a number of these processes. So understanding the category and therefore the algorithms of diagnosis and management is really important to any of us who will come across such patients, so that we ensure that they get the appropriate and timely treatment if they are patients who are likely to respond to it.
No, thank you. Another area that I thought was probably worth highlighting was obstructive sleep apnea. Not necessarily because there's been huge changes in how it's managed, although you can maybe say something about that, but also I think more from my point of view because of its underdiagnosis, the fact that it's been unrecognized. I think that's probably changing. I think perhaps more clinicians are thinking of it as an underlying diagnosis, as a contributor to other diseases. I mentioned my particular area, hypertension. And I think I and my colleagues are getting better at looking for symptoms and signs of OSA in our patients. But maybe I could just ask you your views on that. Yes. Do you think it's still underdiagnosed? Do you think that it's something that clinicians should be more aware of and know a little bit about?
Yeah, absolutely. And as someone who does a sleep and ventilation clinic, I totally agree that it has been underdiagnosed. There used to be epidemiological sort of figures of 2 and 4% of middle-aged women and men who are diagnosed with sleep apnea. We know that is a gross underestimate of reality. And I think you're quite right that people are much more now aware of what its links are and what its associations are. I remember years ago, the American Heart Association tagged it as an independent risk factor for heart outcomes like blood pressure or diabetes or weight. And of course, weight is still the predominant driver and risk factor for it, but there are better ways now of assessing patients. For instance, looking at the upper airway caliber, oronasal structure, jaw structure, and then those patients who are, if you like, high threshold or low threshold arousal patients, i.e., are you a light sleeper or a deep sleeper? Because that can have an impact on the whether you have deep desaturations if you're a deep sleeper, but you don't feel very sleepy in the daytime, as opposed to someone who's a light sleeper who will have fragmented sleep and therefore have the consequences of that, but not have the impact of deep desaturation. So, in a sense, there are sub-phenotypes that we can tease out, and CPAP is not for everyone. And so, there are emerging technologies there. The mandibular advancement devices are getting better in mild sleep apnea. There are newer technologies like hypoglossal nerve stimulation, which are still yet to find their place, but certainly in some patients, if you like, the pacemaker of the tongue to try and reconfigure the tongue and the oropharynx, and then other stimulators, tongue stimulators in the day. So it's a field that has got huge development to come, and there's a lot of research being done on understanding whether we can measure hormones, sleep hormone levels in individuals, because that's still an untapped, if you like, bit of sleep disordered breathing. Why is it that you or I will have different arousal thresholds, and is it something about our melatonin levels or our orexin levels that may allow us to get treatments to help with that? So I think it's really worthwhile readers just reminding themselves of the basics in these chapters, but actually just to tap into some of the precision medicine, if you like, that's now emerging in the realm of sleep medicine.
And I guess we really couldn't get away from a respiratory issue and a respiratory interview without talking about COVID, which obviously is very much in the news. And obviously respiratory viruses have been around for a long time, and we know that they cause seasonal illness and so on. COVID was obviously on a different level. And what was it about COVID that made it so different? I'll just say that we've got a chapter on COVID management in the latest. I think it'll be coming up in the November issue. But what was it about COVID that made it so different, do you think?
Yeah, and of course, everyone will have their own justifiable view on this, and so mine is merely one. But it seemed as if, firstly, there was an enormous concentration and compression of the effects of a respiratory virus in a very short space of time. I suppose that's what a pandemic is, and so people were able to recognize patterns more easily. There was definitely a different pattern to what we were used to in the flu pandemics. I work in an ECMO center, and twice a year we would have a flu epidemic, or a surge, if you like, of young people previously well who would be struck down by a profound acute respiratory failure related to influenza A plus or minus an infection, and they would recover on ECMO. Some of them die. What was different about the COVID situation was that there was the pulmonary microvascular thrombosis component that was much more apparent, and the evidence has now proven that. And that was causing a slightly different trajectory in terms of the recovery of patients, or indeed in terms of the deterioration of those patients. And a lot of work has been done in trying to understand whether so-called thromboprophylaxis, slightly enhanced levels of heparin, were helpful or not. In fact, we found in the ICU patients, if you didn't have a formal diagnosis of a pulmonary embolism, then actually those enhanced levels were potentially harmful, whereas in those patients pre the ICU, they were potentially beneficial. I think the final word is still not out on that, but that was just one of the differentiators from the common severe effects of respiratory viral illness compared to what we saw in COVID. And again, I would recommend that people read that, because the management of COVID as well, in terms of the early days and the recovery trials in steroids and its benefit, followed by the IL-6 inhibitors, tocilizumab and sirolimus. And then we moved, and of course, remdesivir had a role to play. We also found out that there were certain drugs that didn't have a role to play, hydroxychloroquine being an important one. And then the monoclonal antibodies and the antivirals, so the molnupiravir, the Paxlovid, they all had certain roles to play in specific groups of patients. And I think that is important for all of us to actually remind ourselves of. Because there are emerging variants again, and there are hospitalizations, and it's always good to keep abreast of what is now a well-structured algorithm of treatments for different types of severity of COVID. So definitely worth reading that, and it's part of the pulmonary infections themes grouping of the respiratory medicine section, within which there are common and important themes like tuberculosis and non-tuberculous mycobacterial infections. And there's a lot of work that's now developing in terms of treatment algorithms for that, as well as other important respiratory viruses that we mustn't forget about, and pneumonia. So bronchiectasis, cystic fibrosis, these are all individual chapters that hopefully the reader will get an opportunity just to remind themselves and update themselves of new guidelines on, together with the important chapter on the management of COVID-19.
No, thank you, Suveer. And before we close, because I think we've probably almost exceeded our time here, are there any other particular highlights that you'd like to bring out from the three respiratory issues?
Yes, I'd like to just sort of remind people of what the different chapter themes are. There's the lung and health and disease. There's pulmonary infection, as I've mentioned, airways disease, as we've talked about. And then there's sleep medicine and respiratory failure, the interstitial lung diseases and systemic disease presenting in the lung, pulmonary vascular disease, pulmonary oncology, and of course other important chapters where there's new guidance, such as pneumothoraces, pleural disease. So I think each of them has its own interest, and the nice thing about the format is that there are boxes, there are key message boxes, and there are quick, if you like, take-home learning points that one can do if you can't read the whole chapter in one go. So I think it's a really well-written set of chapters by my colleagues, Dr. Anand Shah from the Royal Brompton and Imperial, a colleague of mine, and Dr. Pete Saunders from Oxford have been co-editing, and they've done a fantastic job. And I really encourage people to have a flick through and have a deeper delve.
Suveer, it's been really fascinating. So thank you very much for that skate through respiratory medicine. And well, thank you very much.
Thank you. I really enjoyed it. Take care.